Good afternoon, everyone. It's just 11 o'clock, and so hopefully some more folks will straggle in. So I'm going to start a little slowly. I see people coming in now. Welcome to our Dean's Lecture Series. Thank you for being here in person, and thank you for all the folks that are online. I know there's a robust group out there. We appreciate you participating today from wherever you may be. So thanks for being with us here too. So I want to start by saying I'm Vincent Guilamo-Ramos. Many of you know that I'm the Dean of the School of Nursing and Vice Chancellor for Nursing Affairs. Today's Dean's Lecture Series, and actually the series in its totality, is really focused on inviting expert speakers, distinguished speakers to our community so that we can have meaningful discussions about the most pressing health and social issues that are happening right now at this moment. Our lecture today is part of recognition of Hispanic Heritage Month. And so from September 15th to October 15th, I think we all know as a community, it's a terrific time to reflect on the Latino community. And we're fortunate that today's speaker, Dr. Margarita Alegría, is widely recognized. I would say, in my view, Rosa said to me earlier that she kind of had a research crush on Dr. Alegría. I think many of us have had a research crush on Dr. Alegría. I don't want in any way suggest that Dr. Alegría is a day over 30. But when I was a doctoral student, I remember reading, and I'm 52, I remember reading papers that were just these amazing papers that at that time, they were the leading papers on, I would say, on the epidemiology of mental health among Latino and Asian communities in the United States. And there was all of this tremendous work that was coming out of Puerto Rico in a group that was doing all the psychometrics, the translations, which demonstrating that all the scales that we were using could be improved and that they could be better. And then from that point, it was when I first came to be aware of Dr. Alegría. And then from that time, boy, the work has just evolved, and it's evolved to more than 300 papers, a number of related but distinct areas. And increasingly, the work has focused on systems and really thinking about how do we improve the conditions, the institutions, and the larger policies.
Ahora las condiciones, instituciones y políticas.
I think we have to mute our translator. So I think that...
Creo que tenemos que...
Let's give them a second. That's great. We know the translation is working, which is terrific. Hey. So, I want to repeat that again, that Dr. Alegría's work has really moved to systems, and it really looks at institutions, policies, and the broader context in which people live. And so in our country today, there are roughly 62 million Latinos. We are the largest racial and ethnic minority group. By 2060, 1 in 4 Americans or people who live in this country will identify as Latino. Despite our size and despite our contributions economically and socially, oftentimes we are invisible and there's inadequate attention to our health and social welfare needs. And I would say our contributions as well, which I think are very, very important. According to SAMHSA, the Substance Abuse and Mental Health Services Administration, the most recent data that I was able to identify for this talk today, that there are roughly 8 million Latinos in the country who are in need of mental health services, who have been diagnosed as having a disorder and yet are not able to access those services. We know that 2/3 of Latinos ages 18 and older with any mental health condition are not receiving treatment. And there was a terrific report. Some of you may have seen it. I know that LaWanda tweeted it out from our school account. But Morehouse, the School of Medicine, released a terrific report on the cost of the economic costs of inequities in mental health and the actual cost that is having the burden, the economic burden on our country. And it's absolutely a terrific report. This month, Hispanic Heritage Month, is a time to really highlight the health and social welfare needs of the Latino community. It's a time to make Latinos as a whole a little less invisible. And probably most importantly, it's a time to recommit and to actually try to take immediate action steps to do something to improve the conditions of Latinos and other communities that need the help of nurses and other healthcare professionals around our country. Today we have Dr. Alegría. It's really an honor to have Dr. Alegría. I'm going to do the formal part and move away from the informalities of the research crush and talk about sort of who she is in a public way. So Dr. Alegría is the chief of the Disparities Research Unit at Massachusetts General Hospital and an endowed professor in the departments of medicine and psychiatry at Harvard Medical School. She has spent her career examining how to reduce health disparities for populations of color, with a particular emphasis on Latinos, immigrants, and linguistic minorities. I've mentioned already that more recently, her work has really moved to systems and these very complex, large issues. And I'll let Dr. Alegría say more about that during her presentation. She's currently the principal investigator of a number of studies. There are many, 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 many that I could identify. There are three that I'm going to highlight. She's conducting a couple that are NIH funded. One is called Building Infrastructure for Community Capacity and Accelerating Integrated Care. Another is Building Community Capacity for Disability Prevention for Minority Elders and Latino Youth Coping with Discrimination, a multi-level investigation of micro and macro time. She's also very exciting. I just saw the announcement arrive in my email a day or two ago. She's the PI of the Robert Wood Johnson Foundation grant that is really looking at opportunities to establish institutional policy and systemic changes to increase racial and ethnic diversity in academic health settings. And I think that's really important because one of the conversations that we actually recently just had as part of the Dean's Advisory Council is what is the evidence for the kinds of strategies that work. And I think one of the things that I'm looking forward to is really learning from that webinar about a really good set, a focused set of things that our school can adopt that actually have some evidence and that may be potentially useful to advancing what we all care about as an institution. She has published over 300 papers. Really impressive. I feel like I've worked hard. I have a third of the number of papers that Dr. Alegría has. And she's done training manuals, several book chapters. She's been prolific. She, in 2011, was elected as a member of the National Academy of Medicine, acknowledgement of her scientific contributions to the field. Very well deserving and just, again, an exemplar of sort of the best that we have in the Latino community and across science and researchers of the kind of work that's impactful that we all pursue and that we want to actually sort of aspire to also do. For those of you that are joining via Zoom, there'll be an opportunity to sort of ask your questions. I'll be monitoring. Please use the Q&A function. Everything is being translated into Spanish, and so that's terrific because it means that for the last year or so, the school has been able to reach audiences that are both in our local community and also as far as Latin America. I know there are some folks on today that are from Mexico, so just want to say hello to that group. Without any more delay, let's please welcome Dr. Alegría to the stage. Thank you, Maggie, for being here. Thank you very much. Thank you.
Ramos. Can people hear me?
Yeah.
Yes, perfect. So thanks so much for having me here. It's really an honor. I really find that if we don't go out and really discuss and disseminate our work, it really has a 3 months visibility. So people look at journal articles for 3 months, and after that, you're dead on arrival. So you really have to, if you're gonna do this work, especially you wanna have impact beyond just a publication. You have many publications, but believe me, it doesn't equate with impact. And this is where I find that the important aspect is talking to people about what we have found and also hearing from you whether this is going to make any difference and how it impacts what you think could be done in your own context. So I'm going to talk today. And the first thing I want to say to start this communication is to actually emphasize that my name is here, but it's actually a team. It takes a village to do this work. And unfortunately, I couldn't put the 24 names of the people that work with me in my center, but they're the real big people that are behind the scenes doing the work. And that's really important because my name gets a lot of attention, but they don't get the attention they deserve. So I want to emphasize that it's a team and you'll see them at the end. I have no conflicts to disclose. I have no patents, no devices, no things. So unfortunately, it hasn't been commercially an enterprise. But I can tell you, I really am passionate about this work. As Dean Ramos suggested, I've been doing this work for a long, long time, maybe too long, but unfortunately around 35 years, I've been doing this work. So part of it's not that I have that many publications, it's that I've had a lot of time to do them. So don't think that you should be sort of ranked by your publications. It should be ranked by impact. So I'm going to talk today about 4 areas. I'm going to talk about behavioral health and service disparities in Latinx populations. I'm going to talk a lot about epidemiologic findings because I think there's a lot that we can learn from the epidemiology of the work we're doing. Like, for example, the Mexican-American study that we're doing is mostly an epidemiologic study, trying to look at micro and macro things that happen in context that affect the well-being of youth, of Mexican-American youth and their families. I'm also going to talk about best practices to support the Latino communities. One of the things I'll talk about is the importance that, I started doing just epidemiology and health services research and got very frustrated that I was not getting anywhere and things were not changing. And we decided to change, to do a lot more related to how do you change the models of care and health services for these populations. And then I'm going to talk about, like Dean Ramos said, how I think after doing this work for such a long time and not seeing that we're moving the needle enough, how I think we need to move to different approaches in terms. I want to emphasize that people talk Hispanic, Latinx, Latin-E, different things. One, Hispanic is really referring to language, while Latin-E or Latinx, or however you want to call it, is really talking more about geography. But you'll see that people use them interchangeably, and you'll see that depending on the work, sometimes I'm going to be talking about Latinx or Hispanic, but they're really, overlapping. Let me say, like Dean Ramos said, it's true that we have a big population of Hispanic or Latinx population, but I have to say that even then, even with a large increase of 23% of this population increasing, what we're finding is things have not changed in the sense of having better integration in many of the sites they are. If you look at the newspaper articles today, we have a lot of racial ethnic discrimination in this country that gets perpetuated. We have one of the biggest issues we're confronting is intergenerational conflict, because the youth are growing up in a very US-centric environment. Parents are not there, sometimes not even with language. And then there's conflict in the family about how do you prioritize, things that families value, Latinx families value compared to other things that are not necessarily valued. And we were talking, Rosa and I were talking about the importance of anchoring in ethnic identity and how that really shifts with youth over time as they want to move in social mobility, but it requires giving up certain things that anchor them at the beginning. So it's really hard. I also want to talk about neighborhoods and the experience in neighborhoods, because one of the areas we've moved a lot from is really understanding the neighborhood and how the neighborhood can influence how you feel, can influence how people see you, the perceptions they have of you. So neighborhoods are really important. I also want to talk about immigrants, because there's a lot on the news about immigrants. And one of the things I really want to emphasize, most immigrants in this country are US-born immigrants. They came, their parents came, but the youth are US-born legal immigrants. I think unfortunately, we hear a lot about, undocumented immigrants, but I want to emphasize that is really not the case, but a lot of immigrants that come to this country for bettering their lives of their youth are really having a hard time. Also want to count that Puerto Ricans, I'm Puerto Rican myself, are going down. So that's a group that had a lot of political movement in the US. That population, the numbers are going down. And you can see that most of the upper is going from both Mexican and Central American coming to this country. I want to also talk about language, because language makes a big difference in how people perceive. And I want to talk about the difference between minority versus minoritized. And I think the issue about minority is what we hear most, which is really a social construct. Let's start there. A social construct that is associated by being, from a different culture, having different skin color, having accent, or affiliation with a group with limited political, economic, and social power. And that's really important because that's the part that we should emphasize. Minoritized is an ongoing social process where actually it really is racial ethnic groups' experience of being excluded from practices of the more dominant groups that result in contemporary racism or structural disadvantage. So we talk now more about minoritized than minority, because minority, sometimes you're not the minority at all. I mean, in places like, certain places like Florida, it's not the minority. So they're not the numerical minority, but they are excluded for certain advantages. Also want to emphasize the importance of, and this is an area I'm going to show you about because I think it's so important, whether you grow up as a majority versus if you grow up as a minoritized youth, makes a tremendous difference. Makes a tremendous difference in how you think about yourself, the control you think you have of your environment. And so this is where I think we could put a lot of the effort in making sure that our minoritized youth really have a sense of belonging, of social connections that doesn't make them feel like they're losing opportunity. I want to show you some very disturbing data. Some of the data is they did a really huge sample of high school students in 2020, 2021. And what they found is 72%, meaning almost 3/4 of students said their mental health was worse than before the pandemic. But what's really even worse is that Latino youth were the ones that had the highest of all the groups saying that this was happening to them. 60% of Latinx youth were 60% more likely to report poor mental health than their white counterparts. This is a really striking number because it means our youth are in really suffering. And I have to say, I was telling Rosa, one of the things that one of the journalists that called me to interview me for a piece she's doing was very worried about young Latino males in terms of suicide and the rates going up for young Latino males. We heard it for Black males, also young males. We had that happen, and now we're seeing it in young Latino males. The families are really part of the issue because depression and anxiety definitely has had a big overdose in Latinx families. You can see here that 37% of Latinx families that have youth 18 years or younger, 37% report either frequent anxiety or frequent symptoms of depression. And you can see here that this is something that's affected by income, but it's also affected by other things, like the context in which they live. So it's very important to think if the families are not doing well, how can we expect the youth to do well? So that's an area. I also want to use this data, which I really like the work of Cummings. She showed that not only are they not doing well, but the likelihood of getting good treatment is actually a disparities compared to white youth. So if you look at this graphic, the blue is the white, white youth, the red is the Black youth, and the green is the Hispanic youth. And what we find is they're less likely to have minimally adequate psychotherapy, pharmacotherapy, or the combination of both. as you can see there. And as a result, what we're seeing, and you can see there, the youth not only have less services, but even the quality of the services is going to be less likely to be good. I just want to show you for the overall adult population, you can see here that in terms of Hispanic or Latinos, compared to whites, they're less likely to have even one service used in the past year for mental health. So only 8.7% of Latinx receive any services. So this is for the whole population. I'm going to show you for the population that has need for services, but compared to whites, which is 18.3%. So very different rates of disparities. If you look here for those that have mental illness, so for the total population, around 46% receive any mental health services. But if you look for Latinos, it only goes down to 35.1%. And this is related to many things. Insurance coverage is related, language is related, systems of care not making it accessible. Living in rural communities is also an aspect that we see. But there's a lot that has to be done to change this access problem. Even for medications, I want to show you, because even in primary care, a lot of people are getting their care in primary care today, but only 26.8% of those of Latinos receive a prescription for mental health services compared to 38.8% of whites. So there's part of it. And part of this is actually preferences. We know for a fact that Latinx, many of them do not want medications. They actually prefer psychotherapy, but then there's no access to a psychotherapist to provide this care. So that's a problem. I also want to show you, this is for adults. This is the Agency for Healthcare Quality. They do a report, which I really highly recommend it, because they do it by geography and they do it also by race, ethnicity. And what they find out, I want to show you that last column. There's 172 indicators of quality of care. And what they do with those indicators, within the same areas, they compare whites with Latinx. And you can see there, the red is, it gets worse for Latinx. The indicator is worse for 62 of the indicators. It got the same for 76, and it only improved for 34% of the indicators, for 34. So it means that we're not getting that great care. This is compared to whites receiving the same care. So it's a way of showing a dashboard of how the care is it getting better, is it getting worse. This dashboard, by the way, has been very influential, very, very influential. I used it in Massachusetts, which is where I lived, and they were very angry at me because I was showing not only that we were getting worse, but disparities were getting worse in Massachusetts. So that is also a way of showing over time whether things are getting better or getting worse. Overall, quality disparities, I have to say, happen for all the groups. I want to tell you that 36%, in the quality are worse care in 36% of the measures for Latinx, but American Indian is 40%, Black populations is 43%, and Asian people is 28%. So there is disparities in all of those groups. One of the things we have been doing is we are now doing our clinical trials and interventions in 4 languages to try to change the dynamic of making sure that basically there's more of an inclusion of this population in clinical trials and in service delivery. I want to talk very briefly about language, but if you're going to think about something transformative, is changing language, offering things in the language of the participants and of the service, the clients. We have seen such a dramatic increase in people being willing to participate if we give them the alternative of someone that looks like them, talks like them, and is from that language. But language, more than anything, trumps the showing in terms of people coming and accessing the care. So language is really central. And we know that when we don't offer things in languages, for example, one of the things we show with the pandemic is we had a lot of web-based information, but it was in English. So many of the things we had to translate things for other languages. And now we're trying to expand our languages to 6 languages. We're now moving to expand so that we can include more people with different languages. I also want to show you a third of Hispanic adults report having to speak up to get care. I cannot tell you this is across the board. I have people I work with in geriatrics. I have people that I work with in obstetrics. I have people that I work with in cardiology. And having the opportunity to speak up to get the care they need is so central. You can see here, 52% of Hispanic adults had at least one of those 6 experiences, having to speak up to get proper care, not being taken seriously about what they say they have, being rushed by the healthcare provider. People talk about the healthcare providing standing up or looking at their clock, having less respect from their healthcare provider. So we really need to change the dynamics in the clinical encounter. The other thing we see is the rapid discrimination that's happening both from the police system. You can see here, 33% of Latino men talk about being discriminated by in the police. The issue of licenses is a big one, really, really a big one. In Massachusetts, we're dealing with trying to create safe communities because it's safe not only for the parents, but for the youth themselves. And you can see here, going to the doctor, at least 1 in 5 Latinos talk about being discriminated by their doctor. So it's something we need to change. And it's not, I have to say, people have become very good at being subtle in how they discriminate. So it's not open, expressive discrimination. It's small microaggressions that erode your soul. And that's really important. I wanted to start with epidemiologic findings, and I want to talk about this because I think the issue of place and context is going to be so central, and we should be doing more about thinking about place instead of talking only about the population, but about where our populations are. First of all, for Latinx youth, we know that they're concentrated in sites that have higher prevalence representation of minority populations in those areas, that they live in highly densely populated by minoritized populations. They're in high poverty, and I'll show you some slides about low levels of education and poor public health. And public health is so central to the well-being. But one of the things is neighborhood segregation. And neighborhood segregation, it's an area that now there's a huge interest in neighborhood segregation. But I also want you to think about school segregation, because it also is affecting our youth dramatically. And the same with health system segregation. We know that sometimes it is not so much that providers themselves, is they're segregated in areas in health systems that don't provide good care. Once you adjust for that, sometimes it disappears. But I think segregation is really important, and it requires place-based policies. And that's something I'm going to talk about. The other thing is one of the things I find today is the lack of attention in the clinical encounter. Productivity is such a big name in making sure that people are efficient, rapid, and we actually, the work that has been done on how much time your primary care provider spends with you, it ranges between 3 to 8 minutes. So in 3 to 8 minutes, this person, your primary care provider, imagine how much you can connect. And especially if you have an interpreter, you're dead on arrival, because imagine the connection. But attention, and I say this, attention is going to be the biggest luxury. Getting a provider to really spend time with you and get to know you and have interest in what you have to say. So one of the things is we see this in the healthcare environment, but we also see it from teachers. I work in 2 schools in Massachusetts. And one of the interesting things is in those 2 schools, we got the school people to call us to see if we can help them. And what we find, the first thing we did is we actually did an analysis of who were the kids that were having problems. One thing that really struck us is 98% of the kids having problems were children of color, which may seem like 98%. That's like, so it was like rapidly children of color that were having problems. One of the biggest things was some of the immigrant kids were coming late in their academic schooling. So they really had a complete unalignment with being in school, with having the knowledge of phonetics, things like reading level. And so they were failing, but they were failing because there was nothing to do to help them in. So once we worked with the teachers, they made a big change, and it was really different because we talked in trying to understand the circumstances of those kids rather than trying to say that it was the kids themselves or their parents that had the problem, but actually how the system was really not helping them thrive given the conditions they were coming in. I want to show you this, because one of the issues that we don't think when we think about kids are the poverty. The poverty that now with the pandemic, we saw how poverty had such a tremendous impact. This is showing you before the pandemic. If you look there, Latinx children, 25% were in poverty, a fourth of them. And now over time, this was going down both for Latinx and for Black kids. But as you see, after the pandemic, it went up. And this is an area like we need to be able to have better social mobility for our minoritized populations. You can see there compared to white kids where the difference is 9%. Really, really dramatic difference. And if you don't have resources, a lot of your constraints are going to be there because you don't have resources to do. And with COVID, I'm very quickly going to cover this, but with COVID, it means that this is for Latinx youth. Latinx youth had more problems in healthcare because well child visits had to be taken out. They're more likely to have decrease in routine vaccinations, education and schooling. Loss of childcare and after school activities was huge for Latinx youth. They had horrible broadband, and they still do. The study we're doing in Indiana, we're having to get them computers with broadbands to be able to participate because they don't have good broadbands. And then childhood isolation. One of the things kids talked so much about was isolation. Economics, as I show you, food insecurity because they didn't have food access and the lunch programs. Housing, unstable housing. People had to move because sometimes the rents in certain places went up, and they also were in multi-generational families living. And the mental health well-being in terms of psychosocial stress really had a difference. I want to show you a little bit about that. When we think about changing the narrative, we need to move more to the structural and macro factors. We're too much embedded in the proximal individual characteristics. We're saying we change people and that works, but actually, if you don't change the upper ones, the friends, work, and family, the organizational connections to neighborhood and community, and the political economy and culture history of the area, we're very unlikely to change the needle. And that's why I'm moving upper, and we have to move upstream rather than downstream, which a lot of the work is being done in biology, in changing the genome, and changing all of the things, which is fine, but we need to also make sure we change the bigger one. Also want to talk about one of the things is, and I'll show you some data. When you are minoritized and you live in a context with disadvantage and high risk, it even exacerbates those conditions. It really leads to more negative experiences and stress response to deal with what's happening to you. And one of the things we're seeing in all of this context, people talk a lot about discrimination, but the other thing we're seeing is very high rates of hypervigilance, very high rates of being on the lookout for things that are happening in your environment to try to sort out, is it friend or foe? And that is having an effect that we're seeing in terms of youth. And it's an area that I really highly recommend that you look. This is why I really like this Jerby model, where they talked about the structural discrimination that happens, but how the law, the political process, trying to really embed our interventions in policy, trying to look about budgetary decisions. I was telling Dean Ramos that in the work we're doing, we're finding very few interventions that have to do with budgetary decisions. Who's getting the resources to do what? And very few on regulations. I was also saying for the nursing, there's so much on regulations that could be changed to be more inclusive of what nursing can do, because there's lots of places that are changing regulations. And then focusing on systems, focusing on public health and healthcare, focusing on the neighborhood built environment, because we know that has an impact, and education and economic stability. Families to have that. And that really is what's going to change the dynamic. It's not going to be having more clinicians one-to-one giving care. It's really not. This is a study I did and published in 2019. Unfortunately, it went to World Psychiatry and people from different places read it, but not people in the States. But this is a study that is really looking at low-income Puerto Rican youth growing in the South Bronx or in Puerto Rico. They share many of the conditions in both environments of being in terms of poverty, in terms of different conditions. But overall, I'm going to show you what it means to have one group grow as a majority and one group grow as a minoritized youth. And what we did is we did a statistical analysis. I'm not going to go with propensity score weighting to try to make those conditions a quasi-experimental design. We followed this youth for over 11 years to try to see what happens to them. And I want to show you this. We also use a model. One of the things that I really highly recommend is the importance of using models that are asset-driven, that really talk about the importance of social position, because one of the things that people don't talk enough is where are Latinos socially stratified. And social position is a great way of trying to see where you think you are in comparison to others. Marginalization in terms of identity. It also talks about the protective effect of family and peers, and also the context of other areas besides family that can have an impact. So it's moving away from deficit models to asset models and capturing things that are more unique to that population. I just want to show you very quickly the analytical framework, and you can see there, we talk a lot about the effect of context. So we talk about the site, are you in a minority or majority site? But we also look at neighborhood context with regards to exposure to violence, exposure to your experience and climate in the school environment. We use census data. We were able to get crime data. And then we also have social context and cultural context, how you do in terms of discrimination, social support, cultural stress, social position, and family context. And then we tested all different models for different ethnic groups. I'm going to show you lifetime major depressive disorder. And what I want to show you is how the groups were very similar when they were young, meaning in waves 1, 2, and 3. In wave 1, they were 9 to 14, 5 to 14. And then as they went along, and this was every year in wave 1, every year in wave 2, and then wave 3. And then we followed them approximately 11 years after in wave 4. And by this time, they were either in late adolescence or early adulthood. And what we found is the rates, as you can see there, really vary dramatically. And it is, again, not the youth, but what happens in that context that can put them at risk for depressive disorder. This is anxiety, and you can see again the same thing happening. And unfortunately, it didn't happen only for depression and anxiety. It happened for a lot of the mental health outcomes. And what we found is it really also affected not only the mediators. What we found in terms of the mediators had to do with discrimination, cultural conflict, things that had to do with unfair treatment. But not only that of discrimination, we also found that peer relations and the environment had a big role to play. But what I also want to show you is we did moderators. And one of the interesting things is, for example, an exposure to violence was significant across both groups. ACEs was significant across both groups. So having adverse child events was significant across groups. But there were some moderators that were different. So social position was a bigger explanatory variable for kids in the minoritized environment, but not in the majority environment. You know, so different things explain the patterns that we saw, which is really important because fairly, we don't have a lot of data to do this work. I want to talk about evidence-based interventions, and I'm going to go very quickly through this. One of the things we learned, we did a study, which I really learned so much. We videotaped the first session of providers with a client. And it was a client, an ethnic racial minority client. And we videotaped 189 of the sessions, and then we analyzed them by a team of clinicians. And what we learned about it is that there's a lot of assumptions people make in the first minute that they meet you, in the first minute. So a lot of assumptions, it's like your head goes click, 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 and you actually position that person in terms of their class, in terms of who they are. I mean, people went, so we did that. And also we interviewed them separately coming out of that first session. So we interview the patients and we interview the providers. And what we found is both patients and providers had a very quick reaction to that first minute. So much so that we actually decided we need to do something very quickly, because if it happens so fast, how can we change that dynamic? In this paper, we studied people that started very negative, but over the time of the interview changed dramatically, because we wanted to see, like, what does it take to change dramatically? And what changes dramatically is if you start changing your approach, thinking of your assumptions are wrong, and trying to get more information about that patient. And that's what happened. We talk about one case where the person thought this is you know, a person that's a drug user, and I don't want to keep this patient. I'm going to do a very quick, you know, review of the symptoms, but I'm going to pass it on. And then they had an exchange, and the patient started, she used to call him a thug. She had an exchange with the thug, and then the thug started crying and completely changed her mind of who was this person and what was happening. So that's really important. So one of the things we think in the system of care is making a paradigm shift, meaning really going beyond the hierarchical relationships patients and provider have in the system, so we can change the power dynamics in the relationships. And these are 4 things we learned that are needed to change that power dynamic. Shared decision-making, it really, really makes a big difference. Perspective taking, recognizing bias, your own biases that you have, and also learning about the biases that the client might have, and then building empathy, cognitive empathy, which is really learning about how the more you know about the person, the more likely you are to lower your biases. We also did this paper, and if you have a chance to read it, we talked about how difficult it is for people in the healthcare setting to really work in terms with across cultures. We are not very well trained to deal with across cultures. And this requires for us to change how we do that first interview. It also requires that we get some professional supervision, clinical supervision from someone in that realm. So one of the things we do right now is we have supervision in Cantonese Mandarin. We have supervision of someone that's very well versed in that. We have a supervisor that is very knowledgeable about Black and African American populations and really can think about what are we missing because we weren't trained in that, and the same for the Spanish, the Latino population. I also want to share, we have done work with PCORI on how do you change the clinical encounter. And this was an intervention we did on trying to improve shared decision-making of providers, but also to empower patients to ask more questions. We found the more patients ask questions, the more they change the type of how the clinical session goes. So preparing patients to bring their questions and what's their agenda for their session makes a huge difference, huge difference. We did another study where we are, rather than doing interventions, clinical interventions just on one illness, we're doing more interventions that are transdiagnostic, that really cover several of the diseases in a way that can have impact because you can treat a lot of people with community health workers. This is an example of all the things we do in those sessions, but we train, in this one, we train clinicians, but this could be done by nurses, it could be by nurse assistants, by physician assistants, and it could be done by promotoras, and we're doing that right now. We even included HIV testing, and because they had a really good connection with their person, 76% were willing to do HIV testing before. So overall, we found that we could really improve the interchange, lower symptoms of depression and anxiety, and really even substance use for the cases that had substance use. And this was, a 10-session, basically a 10-session intervention that was very short. And so we found that it was very effective, especially among low-income and immigrant populations. I'm gonna end up with this one. This is Strong Bodies, Positive Minds, Strong Bodies. This is as a disability intervention. And the reason we did this is because we know that functional limitations and impairments are higher in minoritized groups. And what we did here is we identified people that had low mobility, such as problems with balance, walking, whatever, and also had mild to severe symptoms of depression and anxiety. And once we identify them, we offer this intervention. And this intervention is completely by community health workers. And we've done it, we did it, we published on it, showing that this intervention, which is again 10 sessions, and it not only covers the areas of depression and anxiety. People, when we talk to people, they wanted more on self-management. They wanted more about healthy habits. A lot of people were talking about sleep as a problem. So we gave them issues of sleep, nutrition, exercise. And one of the things we found really interesting is communication skills. Really important, because a lot of the dynamics of family, a lot of the dynamics in the neighborhood have to do with lack of communication skills to do a good job. And so we did all of that. We found that the intervention worked. In fact, we just got submitted a paper showing that even 4 years later, after getting this intervention, people are still doing better in terms of depression after the pandemic. So it really maintains the effect. And we published this in American Journal of Geriatric Psychiatry. Last, this is the other thing I'm going to say, and then I'm going to move quickly to the recommendations. We need to make sure that our systems work. This was looking at in New York. We know that substance use treatment for Medicaid populations is most of the care for substance abuse is given by Medicaid. So we work with the office of the actual office of substance use in New York. And we had developed 18 indicators of performance, how good you're doing. And we use those indicators with the Department of New York to then monitor how they were doing in substance use. What's really important in this, and I'm gonna skip this, is that we were able to get, before the pandemic, data, a big data set of New York Medicaid population. In New York, if you don't select your insurance, they randomly assign it to you. So we collected the population that was randomly assigned. So it mimicked actually as a clinical trial. And what we did is we took that randomized sample because if it's big enough, it should be equal across the insurance groups. And what we found, and I'm going to skip this one, is that we are looking at treatment access, treatment patterns of care, and treatment outcomes with these indicators that we got working for 2 years with experts in the field of how could you monitor these indicators and use them in the Medicaid population to see whether they work. It's 18 indicators that we selected based on the literature, based on reliability and validity and application across different types. This has the indicators. I don't have enough time to go through it, but it has things about engagement. It has things about smoking cessation. You can see there it's across a lot of substances. It has inappropriate medications. It has rapid readmissions, treatment continuation. But what was important is that we found that the differences across the insurance groups was minimal. So it tells you, this is important because what it tells you, it is the policy that needs to change. It was not that some groups were really good and others were not that great. It was that they didn't have a lot of incentives and a lot of monitoring of these events, and therefore the system was doing not that great. Let's put it that way, not that great. So one of the things, for example, that we found is monthly expenditures were so minimal. Most people were getting nothing. So that makes for not really getting people better care. So I'm gonna take that here and then I wanna go to the recommendations. My recommendations are really that we need to disrupt the dominant model that we have in terms of mental and behavioral health care. This idea of individualized pharmacological treatments is not going to get us very far. We need to really shift to the community and move our interventions to the community and think about the structural factors that affect wealth, education, and neighborhood conditions, as I show in that presentation and model, if we really want to have a big difference. We wrote a paper in Health Affairs on what do we need to change? How do we change what we are doing? And the first thing we say in this paper is the importance that when you're doing healthcare, you actually first deal with social determinants of care. So now for our interventions, we have social determinants as part of the package, even for the control group. So people at least are receiving something. We need flexibility in regulatory policy. And this is where I'm saying, for example, for nursing staff to be able to give addiction treatment, for nursing staff to be able to do pharmacological treatments and go out to the community. We need to be able to service people with innovative models. The models we're using are the same models we've used for 40 years. They no longer work. We need to get people out to the community and have bans, clinical bans that take the medication to where people are. And we need to create a public health infrastructure. We're really not doing that well. So overall, 3 recommendations, really big 3 recommendations. The first one is we need a paradigm shift from the individual to the system and policy if we really want to make a shift. And workforce infrastructure alignments are needed. Our workforce is trained. We are training people way in the old system. The system has to change, and we need to change it by the alignment of what people want versus what we're giving them. The third one is we need more research community policy partnerships that co-create what people want. I think one of the biggest problems we have is what we're giving is not necessarily what people want or say they need. So co-creation with these groups is central. And policy needs to be involved if we're going to have sustainability. If policies are not there, the political arm, you're not going to have a lot of action. We also need to have a more racially and ethnically matched workforce. That's why we did this Robert Wood Johnson webinar that I'm going to talk in November 7th of what do we find that works to have a more racially and ethnically matched workforce so that people feel that they don't have to prematurely leave. And then we have to reach people earlier. We're getting people way, way too late. It takes a median of 7 years to get someone that has mental health or substance abuse, 7 years, and in some cases, all the way to 14 to get them into care. By the time we get them, it's really problematic. And then these interventions, if they're gonna work, need to be multi-level interventions, need to be at the community level, changing things in the community, like green spaces, like areas to socialize. We need to integrate social services with mental health care. If we don't get social services, people are not going to stay in care. Their circumstances are too dear to really stay there. And then we need to link primary care with mental health care so it's all within the same realm. We have to do one-stop shops. This is our mission, and as I said, these are the people that really hold it together. They're the glue that really make it happen. And our mission is to generate innovative health and health service research that helps shape policy, practice, and service delivery to reduce disparities and improve the well-being of diverse populations. Thank you very much.
Well, thank you very much, Dr. Alegría. We have time for questions. I don't know if there are any in the room. And then we're also going to open up the Q&A. I see some questions coming in, but it would be great to just alert folks that you can actually send your questions in. So the first, we have a couple of comments and a question. So the first comment is actually from Professor Ann Derwin. This amazing presentation. Thank you, Dr. Alegría. Your suggestions for the first steps.
I think for the first steps is creating community alliances. I have to say those community alliances that are partnerships between policy, the research community, and community groups is central, because that's where you really can decide and co-create what's needed. And what's needed varies from site to site. So I think saying there's a one size fits all is not necessarily going to work. I think getting the community, the policy people, and researchers together to try to see what are the community needs and how can we work together to provide it. So that's the first step. I think the other important thing is there are a lot of things that could be done very quickly. I think the policy dimension is one that we know, like we put this in the study, we have a lot of knowledge. I have to say, people say we don't, but there's actually a lot of knowledge out there that we could be using. And it's really amazing that some places don't want to. When we know that flexibility in policy, especially for mental health and substance abuse, makes a huge difference in terms of access and the shortage of personnel. So why are we not doing those things? So that's the second one that I would say, really striving policy. Same for schools. There's a lot of things we could be doing in schools that we're not doing. And then I would say the third one has to do with, if we really, really want to change as a profession, we need to change how we ourselves act. I think we are not very reflective. Actually, people think that health professionals are very good in terms of bias. I mean, they're very good in terms of being neutral and objective. And we're actually not very good at all. So we actually do a pretty bad job, even in connecting to patients. And that has been measured. And what we know is we don't do that great of a social connection. And we actually are not very good in giving our power or equating, the clinical encounter. So I think those three things are three startup points.
Sure. So any questions in the room?
Yes. And then here. Oh, okay, we're gonna start.
I'm pretty loud. I had one question about one of your recommendations in terms of collaborating around social services. My population of interest is, young families, women who are, having new families with new children being born. And there, at least in North Carolina, it's very stigmatizing to access social services for support. And yet they are sometimes the gateway to many interventions, including mental health. And I just wondered if you had thoughts about how to manage and navigate that.
It's a great question. Actually, there is a trial ongoing. I know because I reviewed it. That's a trial where they're actually giving the resources, meaning they're giving you like this list of resources and making the appointments without you ever saying what you need. And then the other one where they ask you what you need, and then you say, well, I need legal aid, or I need, my kid is having problems at school. And they're testing whether what you're saying is actually right. Their idea being that some people don't want to ask for the resources because it's stereotyping them that they need help. One of the things we have, so they're testing that, and I'm sure soon it will come out, and it's actually exactly for young families with children. So they're testing this. The second thing I would say is that in our experience, we find that in the first visit, people are less likely to say they need things, but by the second and third visit, they feel a lot more comfortable because they see that there's not that much difference and that they're being treated like we really want to know. And now it also, they start hearing that, this is something we're going to be asking about. So they start saying more about what they need. And so I think the trust is the biggest area because once people feel trust, they'll be very disclosing.
Sure. There was another question in the room.
Thank you so much for sharing your work. I just wanted to ask your perspective on the role of intergenerational trauma in minoritized populations and any thoughts about intervening to break those cycles.
Yeah, it's a huge, huge area because we know that if we don't treat the parents, the effect on the kids is not going to be long lasting. So I think it's very important to try to see how much we can get with the parents. We find intergenerational trauma very, very, how should I say, very strong, especially in certain communities that have had adverse events, chronic adverse events. So one of the things that we have done is really changing the narrative about from trauma, recognizing and validating the trauma, because I think you need to, but then trying to do more trauma infused interventions that acknowledge the trauma and acknowledge how the trauma has an effect on the family and on the other people. I do, however, want to caution you, we do a lot of our work now. We used to do more with clinicians. Now we're clinicians being social workers or nurses, but now we're doing more with community health workers. And one of the things we've noticed is we have to be very careful in trauma, even on some of the trauma infused work we do, because when people are in too severe trauma, they really, and we start with the trauma talking about it, they're scared and they drop out. So one of the things we do is we really anchor more on going very slowly and being very careful about how we frame the trauma. And sometimes what happens is they stay, but then we need to connect them to more services and then try to see if we can bring the family. And this is one of the criticisms we've gotten of our interventions, I'll tell you that. They criticize us for only having one person when they really want the whole family. So many times they say, no, you let me bring my partner or let me bring my son, and the intervention unfortunately was created that way. But I think now you could start thinking about more family intervention.
I'm going to take a question online and then I'll take the question that's right in the front. So the question that's online, it's about really the diversification of the workforce and really thinking through that at present, the majority of the healthcare workforce is actually not matched. And so there's recognition that we need to do a better job with pipelines, but what do we do about the majority that actually wants to support Latino and other communities that are minoritized?
So that's why we created the CIDE. The CIDE is the intervention I told you about. And we created the CIDE for the client and we created an intervention for the provider. Providers can be trained to do a better job of breaking that bridge between a population that they don't belong to in that sense. You really can make that difference. It does take effort and it takes supervision. And one of the biggest problems we have is we train people, we send them out, and we never give them enough supervision in-house to really make that bridge. And that's exactly what we do. We actually work very much, for example, with both our, we can start working with community health workers, but if we are working even in the clinical encounter, we can have cultural brokers that could be giving us supervision about what we're not doing right. We're not supposed to know how to treat everyone. And we're gonna make tons of mistakes. Don't get me wrong, this is not easy. But you can get supervision, and we don't give supervision on the job. We rarely do that, and that's a mistake. We find that the more supervision people get, the more they get very used to integrating these things in their everyday care. And then they change the dynamic. We see the difference. We did this training. And once we give that supervision, one of the things I'll tell a very quick thing, you should hear your tapes. Go and do a tape of yours and hear how you talk. And I'm happy to send you the scales that we use for people to code themselves. And what you'll find is how many things you do automatically that really silence the patient and really create this hierarchy of power. So there's things we could do, and it's not inevitable to have that division of power.
This was amazing. I know you mentioned I know you mentioned the impact of research, community, and policy all coming together, and I'm so into that. I have trouble visualizing what a mental health intervention looks like on a community level rather than an individual level. So I know with an individual, maybe you would do CBT or mindfulness. But how does that look like? How do you scale that? And when does it happen?
So let me tell you two things, and I'm going to give you different examples.
Yeah.
So in one, we did a clinical trial, and then the community-based organization said, well, how could you train us we want you, for you to train us. So we had to develop a whole different way of training in community, giving them like everything. How do you train it? How you train it fast, how you provide them with the tools, a toolkit. We had to develop a toolkit that they could use in their communities to screen, to really do it. And that's what we're doing right now. So that's one approach. And that is, they wanted mental health and substance use care. So we're doing that. The other approach is to go and start from scratch. We did one where we asked youth. Our idea was we're going to co-create an intervention for youth. And then we asked the youth to tell us what they wanted, and they didn't want a mental health intervention. So that was more challenging because they wanted a civic engagement, civic leadership intervention to work with their communities and get power and be spokespersons for what was happening in their community. I have to tell you, we've never done an intervention on community engagement and community leadership. So it required completely, vamping up what we thought would be a mental health substance abuse intervention, but that's what the community wanted. And that's something that you have to come to grips if you're really working with community. But it actually has ended up being very instructive because it really, really showed how community can have a powerful voice in what we offer rather than what we think they need. And so it's changed the way I think about co-creation as something that really needs to be in place if we want people to adopt what we do. Because right now, people are not adopting. There's only, I think people said there's less than a third of the interventions that we develop that are adopted and used widely. So it means that we're doing all of this work, 5 years, funding, et cetera, and no one's taking them.
So a couple of questions are coming in online. So one is coming from Adrian Delgado. Adrian is the president of the Latino Social Work Organization. And so they're participating today and they're highlighting that they really enjoyed, Dr. Alegría, your comments, and that there's a network of social workers throughout the United States that are interested in advocacy and how can community organizing be integrated into settings. One of the concerns that they're seeing from their most recent conference in Chicago is that many bilingual, bicultural professionals are leaving community health centers.
Yeah, I think the conditions, in terms of having enough infrastructure in community health centers, it's really hard. And some community health centers have such a demand and such a huge group of people coming in that they feel like they're really not able to do a good job. So I can understand that. I think advocacy, I find that nurses are one of the best groups in doing advocacy. They're really organized, they align themselves. I think getting to political power, like, if you look, the medical association has a lot of power. So they get lobbies, they get, people in and they organize. And I think we need to start trying to do more advocacy in what we are doing and also talk to policymakers, go and present to the legislature, be in the town meetings and talk about what's needed. A group of youth went in Indiana and talked to the mayor about how they needed a social worker that spoke Spanish. And they went and organized, the school went and organized themselves and they got their social worker that spoke Spanish. So we need to present ourselves and advocate in every forum if we're gonna make it happen.
So thank you, Latino Social Work Organization, for being with us today. Is there a comment or a question in the room? Yeah.
Thank you. Thank you for coming and being with us. And my crush for you has only gotten stronger. One of the many things that you said that resonated with me, that made me think a lot, are the tools that we have for structural systemic change. And you mentioned one of those tools being budgetary influences. So I was wondering if you had any good examples of any budgetary changes that really influence the shift from the individual to supporting more interventions in the community and the systems, which we know we have all our fundings in the individual for the individual interventions.
Yeah, I think there's going to be more of, for example, making sure that even researchers, we've been very bad about sharing our wealth with the community groups. I think that is dramatically changing. You see it in research, but you see it also in philanthropy, where they really want to see that we're sharing the wealth. And actually, it's part of the questionnaires that they're asking. So they're asking, you know, in terms of budgetary decisions, who is making them, and is it shared equally by the community groups as with the researchers or policymakers? I think they're making more information about, you know, how is the money being used, and whether communities are really getting a fair trade in terms of time and effort they're providing in the same way that it used to be for researchers or for groups. And then I think that's really important. And we've done an awful job, myself included, by the way, in doing that sharing. And I think it's going to change dramatically. But I think the other thing in terms of budgetary has to do with equal pay. I think one of the areas that I'll talk in the November 7th webinar is there are certain things in the health in health settings of changing policies so there's more equality in pay. We know, for example, women earn a lot less than men in the same profession, in the same setting, doing the same work. We know also that ethnic minorities get less. So that, seeing that in black and white makes it very, very tough, because then you have to equate them. And that's something that has happened. So for example, in my system, they actually presented like the differences, and then they equated the people that were in the bottom. And that's a big change. There's not that much about it. There's not that much interventions like it, but I think that's also, I think decision-making is a big one. In the same way as budgets, decision-making, who's making the decisions? Like you want to follow who's making the decisions and who's included and who's excluded. So those are two that I would highly recommend.
So we have an additional question from online and then one from the room. So we have Doctora Maria de Lourdes Rosas from Mexico, who's with us with her university, UPAEP. And Doctora Lourdes de Rosas is asking, first she's saying that what a great conference. Thank you very much, Dr. Alegría, for your comments. I am Mexico, and my work is about migrant populations that go to the United States. In Mexico, we have a care model where the patients are much more close to their providers. It's personalized. What do you think needs to change in the US that will sort of work towards moving the culture of healthcare delivery closer to the patients?
Yeah, I think one of the things is time in the visit. You can't do a connection in a short time, especially with someone that's trying to understand what they have. So I think in the United States, as I said, the time in the visit is very, very short. The other thing that's a killer has to do with changing providers. If you're in primary care, in many practices, you don't see the same provider always. We know in a study that I did a long, long time ago, looking at different systems of care in different countries, some of the countries that did best were the countries where the provider was your provider forever. So you got that person assigned to you, and that person made a connection, a long-term connection, rather than seeing you as a one-shot deal. It was someone that they were responsible for. So it established a long-term connection, which I think makes a big difference. Like I try to select a provider that I have a relationship, because I know they're going to care for you. They really care for you. And my husband says, you're not looking at the, are they good or bad? And I said, no, because I really want someone that really wants to hear me and connect with me.
Thank you so much for your amazing presentation and this opportunity to ask questions. So I've made a connection between two things that you said in your talk and something in the answer session. I'm curious if that connection is right. One thing you mentioned a rise in hypervigilance amongst youth that you're noticing, and then I also heard you say that in the project that was more participatory, that youth seem to have this desire for civic leadership. And I'm curious if you see those as connected, as the hypervigilance being kind of a need to do something and be engaged, or how you're making sense of maybe those.
Not necessarily.
Okay.
Not necessarily. It's a great connection. I wish I would have tested that, but no. What we are seeing is there's a lot of surveillance going on because of crime-ridden areas. And that surveillance, rather than being good, it's actually having a negative impact. It looks like a negative impact on youth, on feeling that they can socialize externally because they don't know how that information of surveillance is going to be interpreted. So that's having a negative effect. And I didn't really even thought about it until they started giving examples of how that really affected going to the basketball and not being there, because if something happened, they could use that information against you. So that was an issue. In terms of hypervigilance, so hypervigilance is something we're hearing a lot. And I think it's tied more than anything to the anxiety that you see escalating in youth. We didn't see that much anxiety, but now you see, and especially hypervigilance in the sense that now everything is in social media. So you don't know how that information is going to be used to you. In terms of civic engagement and civic leadership, I think youth really feel they don't have a voice, that there's a lot of interventions that are being done out there, but it's not what they would have selected. For example, the youth in one of the areas that we collected, what they wanted, which is tied to that actually, was they wanted a place they could socialize inside, that they would have a space, because they felt like the parks were being used by the younger kids, but they didn't have anything for the high schoolers where they could have like music or play games or have different types of activities so that they could socialize. In another place, kids decided, or youth decided, that the issue was affordable housing, and seeing their parents' gentrification making an impact in moving them from one neighborhood to the next based on the rent, and how the rents were escalating and they had to leave their schools. So one of the things why I'm thinking is so important is context, and really making something that's context driven more than driven by us.
Yes. So while we're waiting for the next question, Giselle, we will be sending a recording out, so no worries, we'll get that out at some point in the next couple of days.
And you'll have the slides, so feel free to use the slides.
Thank you, Dr. Alegría. This has just been such a compelling presentation. I have a little bit of a different question about researcher development. So many of us have been doing research for a long time in health, and now we really are excited about trying to ask questions that will make a difference related to health inequities and social determinants of health. And I heard you very clearly say that the first step is partnerships with the community. And I think for many of us, that's going to be a big step, just even doing that piece. But I wondered if you had any advice for developing the research workforce that really want to move more towards taking their program of research still in areas like chronic illness, palliative care, but how we can start shifting it to asking the questions that will help us get answers for the health inequities.
Yeah, what you're saying is, I'm very glad you raised that question, because it's not necessarily, we have not necessarily been well trained for partnering with community. As I said, when I started, I was terrible. And I also was very anxious about doing the work that the institutes that were funding me were asking me to do, and was like very worried that I was changing because the community was saying, that's not what we want something else. And so it really was, it was not an easy transition. I think the other thing that you were saying is how to move the questions to the questions that the community wants versus the questions that we are knowledgeable about. Because if you're not knowledgeable about an area, changing your research is not that easy. And I have to say, in the way we did it was we had gotten enough time with the youth, around 2.5 years, to really start getting what they thought about and how to integrate it. So it's not that we were so smart or like we really knew what we were doing. In fact, we felt that we were building the plane while writing it. And so we made some mistakes along the way. We needed more training of the facilitators. We needed more feedback from the participants. So it took us a while, but I would say be patient. Think about iterations of your work. Don't think about like you're gonna get the model right the first time, but rather you're gonna have to try it and then try it and try it. And as you go along, it's gonna get better and better. And then I think community advisory groups are fabulous. I mean, right now with I have several faculty that are doing case, and the advisory group has been tremendously informative to them on the measures, on how to ask the questions. We have, for example, one that's doing an intervention with actually social workers that see families where the child has been an object of sexual abuse, and how to bridge that interface and how to ask the questions to create an intervention. It's been wonderful to have, like people that they do focus groups, they do in-depth interviews. So that's what I would recommend.
So we have time for one more question in the room. There's one online, and I actually have a thought as well. Anybody else want to ask a question? So online from UNC, from the School of Public Health, a doctoral student is just commenting on how much they enjoyed your presentation, but wants to sort of draw attention to the important role of schools and how schools present an opportunity to reach Latino youth, and just wanted your thoughts about ways of being able to do that effectively.
Yeah, I think, and we really love the idea of working with schools. I have to say, it is challenging to work with schools because today you have to go through all this process of getting, the Department of Education to agree, the IRBs to agree. So it's challenging. But I will say that you really get a huge amount of, networking that is very early on that could be very useful for the purposes of disparities work. So one of the things I highly, highly recommend is that you do connections with schools even before you start your research. So one of the things that we are trying to do is really connect to them and see what they need. And so if they need something related to parents and parenting skills, then we say, who is on the team really good at parenting skills that we could give something to the schools about it. I think we need to be more in place than, research outside, but it does take time. And tied to that, I'm gonna say for the dean here, we have to change our policies of promotion. Because part of the problem is promotion is really grants and papers and not really doing the work. And what we're doing, actually, Harvard is changing their promotion criteria, where actually community work has become one of the indicators that we're using. And the other thing is for recruitment, we definitely in searches, we ask, what is your connection to community? What work have you done in the community? And believe me, if people have not done that work, you're not going to do a good job in your interview. So search committees are really important, and changing the policies for promotion.
So one final question is really focused on our school. So our school's been working, Dr. Alegría, and trying to think about how we as an institution can advance health equity and be more inclusive, diverse, exactly what you were reflecting in your entire presentation. I think, like many institutions, we had many recommendations and suggestions. And I'm interested because, and I sort of know, just in the spirit of full transparency, last night at dinner, we talked a little about some of the recent work that you've been pursuing. And there were a set of focus recommendations that seem to be supported by triangulation of the research, interview, and then also comparison of institutions that are doing it well, institutions that are maybe having a little bit harder time. And so I don't want to give away the November 7th webinar, but I would like to just ask your thoughts, because I think we need some assistance in kind of thinking about that as a community. What could we focus on that would help us to advance?
Yeah, I really honestly believe that 80 is not necessarily realistic to do. So I'm a big believer in things that are achievable, because if not, people become frustrated and give up. And so you really rather have a smaller set of things that you want to do, not necessarily discounting that the others need to be done, but things that people then start seeing as we're moving in that direction. Because if people don't have hope and optimism that this is a change, they're going to stop. And I could tell you, this is one of the things I'll be presenting in November 7th, is the amount of skepticism in people in that these things are working is extremely high. People really are not sure even the things that are being done for good intentions are going to work, because they see that some of the recommendations are too hard to shift. So you need to definitely do things that you get a lot of buy-in for the majority of people. That is how I would have selected, is what are the majority of people of all of the 80, which are the ones? And look at the webinar. We found that it's only 13 areas that really have shown quite good evidence. Only 13 areas. So it's not like there's tons of things. There's a lot of talk, but evidence is not necessarily what's there. So I recommend that.
Thank you very much. Thank you.
Staying with me. I know that this is a lot of time, and I said time is a luxury.
So on behalf of the Duke University School of Nursing, a small token of our appreciation. Thank you very much.
Oh my God.
I think they want to take a picture of us.
Oh, okay.
Should we take, I'm going to take this off.
And I should. Somewhere. So I don't get them.
Well, we can hide it. Let's hide it. A little bit wide. Okay. Is that a nice
better?
picture, Drew? You got a good? Thank you. Thank you very much. Thank you.
Thank you for being here. I know.
Thank you, guys. Really appreciate everyone being here today. Those of you online, thank you so much. And thanks for those of you in person. It was a wonderful event.